So our first lecturer is a professor and chair of the Division of Surgery at Stellenbosch University. She's the chief specialist surgeon at Tygerberg Hospital in Cape Town, subspecialist in trauma surgery, trauma director, and head of the renal transplant program at Christian Barnard Memorial Hospital. She's the president of the International Association of Trauma Surgery and Intensive Care, IATSIC, and the Board of Health Professions Council, the Council of the College of Surgeons, the Association of Surgeons, and executive committees of Transplantation Society and Surgical Research Society of South Africa. She is the past president of both the Transplantation and Trauma Societies of South Africa. She is a co-editor of several handbooks of trauma and has had the privilege of lecturing on trauma care and trauma surgery in many countries worldwide. So our first speaker is like Wonder Woman. She is passionate about teaching life-saving surgical skills, about prevention of violence and injury, and about developing effective trauma care in Africa and the world. And like Wonder Woman, Professor Elmin Steyn loves flying and collects art. So ladies and gentlemen, let us all welcome Professor Elmin Steyn.
So I'm the first speaker. I'm very honored. Thank you very much for having me. I am Elmin Steyn. I'm from Cape Town. I'm a trauma surgeon at Tygerberg Hospital. And I am talking to you about trauma systems, but I'm talking from a perspective of what we need to change and what we need to improve, as we know that there are always things changing in the situation in the world, and there are many things that we can improve. And I'm talking about the lower income countries, the resource challenged countries, and in fact, most of us are resource challenged in some way or another. Very few of us have everything we want at all times and complete funding for everything. So we know that a trauma system is a system that entails the pre-hospital care, the in-hospital care, definitive care, and even rehabilitation, and includes even prevention systems. That would be the ideal setup for a trauma service in a country or a region. Now, we all know, and that's why we're here, that trauma all over the world, especially in the lower income countries, remains a very significant problem, and that injuries and violence and environmental disasters and terrorism and vehicular accidents, car crash and vehicle-related injuries are a huge burden on many of the developing parts of the world. Now, there have also been some benefits, some improvements, and in many parts of the world where road safety measures have been extremely successful, measures like gun control, safety in the workplace, seat belts, a lot of that with very well-funded government-based improvement projects or educational projects have actually led to a change. But unfortunately, this is not true for all regions of the world. There are many areas of the world, Oceania and Sub-Saharan Africa, where there has not been a reduction in the burden of injury. And in fact, in some areas of the world where development is such that more and more vehicles are being made available to the population, there's even a higher injury toll because of vehicular accidents. And of course, we are dealing with interpersonal violence and war zones in many parts of the world as well. But the Lancet Commission on Global Surgery in 2015 started to promote universal access to safe and affordable surgery and anesthetic care. And this has given a huge impetus to the push and to create mechanisms with which lawmakers and policymakers can be influenced and encouraged to create, to put more funds and more energy into trauma systems. And as we all know, previously the emphasis was on HIV, infections, malaria, those things, and lots of funding went into those. But trauma and surgical emergency care was very underrated and underfunded for many years. Indeed, the WHO have also helped us by creating the Emergency Essential Surgical Care Program, which in addition helps governments and encourages governments and groups to capacity build and train, and they provide information for workshops and for training and for setting up equipment and systems. And injuries feature very strongly in this program from the WHO. So there is recognition that trauma is important and can be better managed. Now, what is the ideal trauma system? I'm sure many of you have very good trauma systems in your country and are looking at fine-tuning them. In my country, we have some areas that are pretty good and some areas that are really poor in the trauma care provision. This is a beautiful little graphic from Norway, where they have a very nice system already. And we all know that a trauma system has many elements. It varies from bystander care, so it's public education, to pre-hospital care, equipment, people, distance traveling, hospital care, emergency rooms, operating rooms, intensive care rooms, anesthetists, and rehabilitation. And we know that there are many different systems for different setups. The military have excellent systems. The cities, countries, regions, each system needs to be adapted to fit the needs of that area. And of course, there's always quality control and improvement and communication and training that can go on. But for most of them, most of us, finance remains a limiting factor. So we can't always have everything what we want, especially when it comes to the greater healthcare picture. And therefore, we have to focus on the essential. And so what are absolutely essential functions for emergency care systems? And what will we tell our regional governments, our policymakers, our health administrators, our funders, where to start and what can we do without? Well, the answer to that is that we have to convince them that every step of the way is important. All links of the chain are equally important when it comes to a trauma system or an emergency system. And before we can really advocate for improvement or creation of trauma systems, we also need to be able to assess the gaps. So as healthcare professionals, as surgeons, part of our job would be to improve the system. And therefore, it is important that we also are involved and able to assess our systems for gaps. And I'll discuss that a little bit later. Of course, there are unique threats. Every region, every city, every country have different threats, and we need to take that into consideration. And also the trends for the future. So what's changing, what's happening in the world. If we start funding systems now, we're actually looking at quite far in the future in order to not having to change things every year. And of course, then we have to sort out priorities. If we want everything, we're probably not going to get everything all at once. So we need to also prioritize. But when in doubt, if there's anything in doubt, where to start, where to build, training, you can make no mistake if you facilitate training. Every aspect of a trauma system, training is important. And even before the system is perfect, training is the way to build it up and to get there, so that you're never wrong if you promote training. So probably in lower and middle income countries, a road injury burden is one of the biggest burdens. And as vehicles and roads are increasing, so the injury burden will increase. And that's not going to change. It is considered something that will be getting worse. And we need cost-effective interventions. These are some of the tools that one can use for assessment. This is just a small sample of what is available already. There are certain assessment systems for pre-hospital services. There are guidelines for trauma centers, and guidelines are needed because you need people to attain a certain standard, and that can be achieved through accreditation, and therefore you need to have guidelines in place, and that is going to be different for every country, even every region. And then, of course, it has to adapt to the needs of the population, of the people of that region. In South Africa, we have various levels of ideal trauma systems, but in Cape Town, where I live, it's quite interesting that we have some really good functioning systems and some not so great. In most of the world, we need to look at issues such as access to care. So can the patient get to where the treatment is going to be provided, and what are the obstacles? Is it public transport? Is it ambulances? Is it geographical issues? We need to look at injury patterns. So as I mentioned, injury patterns are changing. As road networks improve, there'll be more vehicular accidents, but there are other things that affect injury patterns, such as climate change, such as disasters, such as violence and conflict. So all of that will depend on what's happening in that particular region. We also need to look at disaster management capabilities, because we have more and more have to plan for environmental disasters. And then, of course, there are some areas in the world where terrorism, conflict, and violence are still escalating and a significant factor. And interestingly enough, we also have to look at COVID-19 and how that is affecting our emergency services, because ambulances are involved in transporting patients with COVID, and is it taking away from their service to injured patients? And that may well be the case. Even in Cape Town, we found that we have much less resources for injuries. And also trauma has increased because of COVID for many reasons. So for us, the COVID-19 has certainly affected our ability to service and to look after and to reach our injured patients. I've looked at terrorist incidents in the world. There were years where that really increased in number, but it seems to be a sort of a steady state, up and down, but ongoing. There are various parts of the world that are vulnerable. And I think that there was, as the ISIS, Islamic State, and certain ethnic conflicts will flare up from time to time, and there are trends that would be very region specific, and these need to be considered in a trauma system. Unfortunately, there are extremists who are even exploiting COVID-19. And apparently there are some extremists who actually have exploited the fact that people are at home, they're angry, there is economic uncertainty, and they are vulnerable and to fall victim to both extremists on the right side, such as this Boogaloo group in the US, who are very militant and carry weapons and wear fancy flowery shirts, quite interesting. And then, of course, on the other side, there are other religious extremists who are also trying to exploit these vulnerabilities in our population. Local challenges are always there. We know that in many countries, the preventable nature of injuries has created some very good public prevention and advocacy and training programs, and we can learn from each other. I found these cute little infographics on tsunami response and earthquake response for the public. Very, very useful. I think, this is what people want to see nowadays. They don't want to hear long lectures. They don't want to attend courses. Everything should be in a very visible, social media based version. And if you make nice infographics, you can probably reach a lot more people, especially young people, and convey the message in an effective way. So injury prevention must be part of a trauma system. There's no doubt that a lot of injury is absolutely preventable, and public education is the way to go. And if funding is not made available for that side of the trauma system, then we will be treating stuff that should have been prevented, which is what we do in any case. So a lot more prevention is what the world should be going for. Disaster preparedness. This is also an eminent and evolving issue. And I think we must emphasize climate change and how that is going to affect many parts of the world more and more. And of course, what are the obstacles locally? Are we asking people, or are we telling them what they need? Are we actually designing a trauma system around what is already there? Or are we assessing the local needs and where the biggest problems are before we design a system? Team training is also important. We tend to focus on surgeons and their skills. We tend to focus on pre-hospital teams or the ambulance-based rescue, but we rarely do our training on a broader level where we take the whole team and say, in this hospital, let's look at the team and how they adapt and how they fit into each other. And are we including anaesthetists, and are we including the nurses, and are we including the operating room nurses and the critical care ICU people in trauma care, because that surely should be part of the team. Then data collection. In many places of the world, this is so easy and so automatic, and the systems are there. In other parts, we actually have to make a huge effort to be able to collect data and utilize it efficiently. So this is all about developing the systems. And then of course we have to deal with politicians, with funders, and sometimes even with the police. And because a lot of injuries, especially where I work, is criminal, interpersonal violence, gang activity, and things that are also very preventable, but not being effectively managed at the moment, leading to a really big burden on healthcare systems. In fact, there are some areas in gang-infested areas in Cape Town where the pre-hospital people won't allow an ambulance to go. So if somebody's shot there, they won't go and fetch them because it's too dangerous for them. So these are things that are really is almost out of the hands of us, unless we become the advocates and we speak up. So when it comes to trauma systems and the improvement of trauma systems, I speak for my own country, where we have some resource challenges in most places, and our challenges are probably much the same as many other countries. And what I can say is injury prevention should be a priority, that the access to care, surgical emergency care, remains a very big burden or problem, obstacle in many parts of the world where there's not well-established ambulance systems or air ambulance systems, which is most of the world. And the individual patient, it's up to them to get themselves to hospital, and that is very problematic. So we can improve our trauma systems and our pre-hospital care, but education is probably the most universally cost-effective and beneficial way to go. In education, basic trauma care education for clinics and remote areas, for people who are the first providers of emergency care, and advanced trauma surgery training for the surgeons and the teams, the anaesthetists, the operating room teams and the nursing staff involved in those situations benefit immensely from advanced surgical training like the DSTC courses and the basic trauma training like the NTMC courses, both offered under the auspices of the International Association for Trauma Surgery and Critical Care, IATSIC. Right, so in conclusion, I think that to improve our trauma systems, we constantly need to be looking at what we need. Why? Because trauma patterns are changing globally, all over the world, patterns are changing. And as we need to prepare for the future, so we need to start looking at what's happening and how to predict which way this will go. And is it going to be, do we need to fund in anticipation of what we expect? I think that we should look at the communities. We should train lay people a lot more to provide emergency care, stop the bleeding. And as medical professionals, yes, we all need that. We know we need training, but we don't always take that responsibility of the advocacy role. Surgeons generally don't really want to get involved with politicians. Surgeons want to be in the hospital and they want to fix things. But as surgeons, we're also very well placed to be able to say, this is the consequence of crime. This is the consequence of poor roads and poor law enforcement and poor vehicle maintenance. And therefore we are dealing with those consequences, and we are the ones who should be pointing out to the government, to the lawmakers, to the funders, this is what needs to be done. So ultimately, injury management is a collective task. It's not just us who fix the fracture and take out the spleen. It really takes a lot more than a surgeon to improve a trauma system. And I really like quoting Barack Obama, and I paraphrase him, and the thing is, can we match reality to our ideals? It's great to have ideals, but can we match the reality to that? Thank you for your attention.